excited. Okay, we're live.
Live, okay.
Yeah,
Here we are.
live recording.
Well, as you know, Dr. Coletti asked me to do this to help you all out in the ICU, is my understanding, as you're taking care of these POI and COVID patients. I'm going to start with what I thought was a good introduction, and then happy to answer questions and go into any other issues you're concerned about. So here we go. So my focus obviously will be from a nephrology perspective, but let's start with IV fluids. I assume, obviously everyone has the basics, but a key thing is avoiding volume overload in patients, and that's a notorious problem even before COVID. So what is a proper resuscitation and what fluids to use? Now, lactated ringers has gained more popularity even in the nephrology world as protective on the kidneys. So assuming a patient does not have hyperkalemia or significant alkalemia, because lactated ringers has lactate in it, which metabolizes to bicarb. That's a very useful fluid to use in resuscitation and maintenance fluids. Normal saline is obviously a go-to fluid in an emergency until you know what's going on. But what is a proper fluid resuscitation? One recommendation is usually based on DKA, or septic shock, is 30 milliliters per kilogram. So if you have a 100 kilogram person, you want to, you can pump in up to 3 liters of fluid reasonably well if they're could be volume depleted or hypotensive. But since it's not always so clear what to do, I tend to, especially in our patient population who have renal failure or heart failure, they can easily get volume overloaded. So, reassessing after each liter of fluid is not an unreasonable thing to do. What's the hemodynamics, what's the urine output, what's going on. So you could always start limiting fluids, again, to avoid this fluid overload. So even before the this COVID epidemic, it was well recognized in the nephrology world that there's a tendency to fluid overload our ICU patients, and to get away from that, it would be important to minimize pulmonary morbidity. Early use of diuretics, early dialysis, not waiting till they get 15 liters positive, and then you get into trouble. And again, with this patient population at high risk of dying from ARDS and pneumonia, you want to keep them on the dry side. And what I like to always avoid is the extremes. I hate, you anticipate things. I always hate to react. You get so fluid overloaded, then you have to diurese. So kind of anticipating, hey, they're reaching a good healthy volume status, we can back down the fluids. There's an easy tendency to let the fluids continue to go, and you have to look at weights. You have to look at the urine output. When is it safe to back down fluids? Are they eating and drinking? Because that's another fluid intake. So if they're eating and drinking, I have a tendency just to really KBO fluids or get rid of them. If they're not eating and drinking, then obviously you have to decide what's a maintenance fluid to give once you feel they're euvolemic. So also a nice caveat to that is, if early use of pressors, if after 3 liters of fluid you're giving a patient is still hypotensive, you can still maybe give some more fluid, but maybe it's beginning pressors if they're still hypotensive early on, rather than waiting till they're 10 liters up. It would be a reasonable thing to do. Levofed is the drug of choice in our world, and I think in the ICU world, the general medical world, before we use phenylephrine or vasopressin or, God forbid, epinephrine. Epinephrine is usually the final. It's usually a bad sign. So Levofed has a more kidney-friendly agent. Phenylephrine is the most notorious. It's a pure vasoconstrictive drug. So you want to try to stay away from that unless you have to use it because of tachycardia. So again, assess volume status by exam, vital signs here and output, and go from there. Any questions on this? So also, well, that leads into kind of avoiding the extreme electrolyte changes as well. So monitoring the potassium, sodium, bicarb, calcium, phosphorus, magnesium. You know, adding potassium chloride to fluids and changing to half normal saline to minimize the salt load when appropriate, or changing to lactated ringers. And just, I assume you guys know what the electrolyte content of LR is, but to go over it. Each liter of lactated ringers has 4 milliequivalents of potassium chloride, 28 milliequivalents of acetate, which is broken down to bicarb, and then 2.7 milliequivalents per liter of calcium. So it's a very plasma neutral solution as opposed to pure normal saline. Now we have data that this is potentially a good thing over normal saline in our AKI patients anyway. So what do I mean about, you know, anticipating things? So, you know, if you're planning to diurese a patient, the potassium is 3.6, 3.7, and they're making good urine, you know, giving some potassium early on, either in the fluids or IV or PO to reduce the risk of hypokalemia. Now, because we're now using hydroxychloroquine and azithromycin, there's this concern of lengthening QT intervals. You guys familiar with that?
Mm-hmm.
And with that, you could develop torsades, you could get life-threatening arrhythmias, and what will increase your risk of torsades is hypokalemia and hypomagnesemia. So as you're diuresing these patients, keeping their potassium at least 4, the magnesium at least 2, is going to help prevent this arrhythmia, these life-threatening arrhythmias. So, and again, I like to anticipate if you already see things trending down, you could intervene a little early. You don't have to wait for potassium to be under 3 to give them potassium. So the sodium content in lactated ringers is 130 milliequivalents per liter. So just to be aware of that. Normal saline is 154. And half normal will be obviously half of the normal, which is 77. So again, salt is what drives volume. But when you measure serum sodium, it has nothing to do with your salt content. So it's a very difficult concept. It has to do with the kind of the way the kidneys are handling water. So if the serum sodium is very high, that means the kidneys are getting rid of too much water. The patient's actually water deficient. If the serum sodium is too low, they're water toxic. So you could be water toxic, meaning your serum sodium could be 125 and very dry, very hypovolemic. So volume status has to do with total salt content in the body, as well as albumin and that type of thing. But the actual measurement of serum sodium has nothing to do with total salt content. It's a fluid, a water balance thing. It's how well the kidneys are handling water. So basically, if you drink, 2 quarts of water in a couple hours, you can get pretty water toxic. Your kidney's job is to get rid of all that water quickly before your serum sodium drops too quickly. So that's why, changing, electrolytes, so if you see your patient's serum sodium is 145 and climbing up, so, so I see this a lot. Serum sodium, they come in at 135, and then you're going up to 140, 145, and they're still on normal saline. You could start switching the fluids down to a half normal, a quarter normal saline, depending on things.
If you switch to like a half or a quarter, are you concerned at all about it being not as isotonic, the fluids you're giving?
Yes, I'm not concerned. I mean, so when you volume resuscitate somebody, you want to use the isotonic fluids.
Okay. So maintenance?
So for maintenance, it's a totally different ballgame. Okay. So you just want to maintain a steady state. So, again, if you're given in these ICU patients where they have a tendency to develop, fluid leakage in the lungs for various reasons, you want to keep them on the drier side. So unnecessarily give them more salt. It's just then you're going to have to potentially diurese more.
Okay.
So it's a subtle point. It's more, you know, for our, you know, when we get diagnosed, when we get consulted for hyponatremia, serum sodium of 120, and I assume if you're familiar with the too rapid correction can cause brain damage, the osmotic demyelination syndrome. So, but you know, how this all affects the brain when someone comes in at 130 and before you know it, quickly the sodium goes up to 145. You know, it's not well documented, but I'm sure there's some stress. But so for a couple reasons to, you know, just to keep that in the back of your mind. You know, again, the goal here is to keep them properly fluid balanced, not overloaded, not underloaded, not an easy thing. You know, there's a lot of ways to assess volume status. The other important point is adding D5. If a patient is not receiving enteral feeds, you know, starting D5 probably within 48 hours is not a bad idea. There is an issue called starvation ketoacidosis that can occur, and that just can complicate your acid base problem. So when patients are not getting adequate calories, and they're, you know, hypermetabolic, they could develop that situation, and then you're dealing with a problem that can be prevented. So they're getting a little acidotic, and you think, oh, maybe they're becoming septic. No, it's because they're not getting calories, so they've changed their cycle to create ketones. So, but it doesn't happen too often. I've seen it a few times in the hospital. That's something to be aware of. And so adding that to fluids if patients are not getting any nutrition. And then when to use bicarbonate in IV fluids, you know, the two most common reasons are they're acidemic or they have rhabdomyolysis. Just to recognize, each amp of bicarb that you put in a bag of fluid is 50 milliequivalents of sodium and bicarbonate. So generally you don't want to mix bicarbonate into normal saline because that'll be a hypertonic solution. So normal saline is 154 milliequivalents of sodium per liter. Patient's normal serum sodium is 140, so you're already a little hypertonic. So you add an amp of 50 or 100 or 150, you know, you're developing hypertonic solutions. So we sometimes do that if the patient's serum sodium is low to help the kidneys get rid of water. But generally, if their serum sodium is in the normal range, we usually add, you know, how many amps of bicarbonate you want in D5 or sterile water. So 3 amps of sodium bicarbonate is the equivalent of normal saline. It's 150 milliequivalents. So that's what we generally use when we're trying to correct an acidemia or prevent rhabdomyolysis-induced acute kidney injury. So not all serum bicarbonate being low is a patient acidemic. So there are cases so just because the serum bicarbonate is low, especially if they're in respiratory issues, it'll be important to get a blood gas. ABG is the most reliable. We tend to use VBGs, and that gives you not a true reading on the pH because there's a higher PCO2, so the pH will be falsely lower a little bit. I think about, so you could estimate that with a VBG, the PCO2 goes up by 10. So if you want to correct, what would an ABG look like if you reduced your PCO2 by 10? But the VBG is fine, you just have to take that into account. But if a blood gas, a true blood gas, the pH is, you know, 7.3 or better, or higher, then you probably don't necessarily need bicarbonate drip. Where bicarbonate is very important, and correcting acidemia is very important, is when they're in septic shock on pressors. Pressors lose their efficacy when the pH is under 7.2. So you're struggling to get the blood pressure up, you know, when you're adding pressors, and the pH is 7.1. Well, getting the pH up to over 7.2 with bicarbonate,
sorry guys, looking for dividers.
You know, can hopefully improve hemodynamics and make the pressors more efficacious. So, so anyway, so back to the acid base. So, so the patient comes in with a bicarbonate of 18, and they're huffing and puffing. That could be an appropriate response. If you did a blood gas, the pH might be 7.4. They wouldn't necessarily need bicarb because that's how you compensate for respiratory alkalosis. As you're dropping the PCO2, patients are becoming more alkalotic, and the kidneys are trying to compensate by getting rid of bicarb and to make to allow more acid to build up to keep the pH, you know, in the normal range. So, so it's and so anyway, to bear that in mind, two classic situations where patients will have a metabolic acidosis that's appropriate are cirrhotic patients. They tend to have a higher respiratory rate. So it's if you have a cirrhotic patient who's a bicarb of 18, that's probably appropriate for that patient. Pregnancy as well. When you're pregnant, you breathe faster. So very common to see pregnant women have bicarbs of 18 to 20. You know, below 15 obviously would be a concern. And another important point, I think, is maybe not appreciated. Many of our obese patients are COPDers. They tend to have a respiratory acidosis, so the kidneys are compensating by holding on to bicarb. So you would expect to have a bicarb of 28 to 30 in most of our COPDers. So this is probably underappreciated. So a bicarb of 20 or 22 we may not be too worried about. But if you did a blood gas and the PCO2 is real high, you know, patient's bicarb should be 28 to 30. So you might add LR, which would be so LR, you know, again, that breaks down to bicarbonate. It's a good solution to use in these patients. Normal saline can aggravate metabolic acidosis, especially giving too much of it. That's one of the theories why LR may be beneficial in these patients who have kidney disease and other issues. But so if you have a COPD or PCO2 is pretty high, so you might, and there are normal saline or half normal saline, and you don't want to use a bicarb replacement. You could use LR, and use the oral route when you can. I think that's important. When patients, you know, especially in the ICU, checking the magnesium is important, especially if the potassium is low. If the potassium is low, there could be a little resistance for it to normalize if the magnesium is low. If the magnesium is low, the kidney has a hard time holding on to potassium. So correcting the magnesium will be helpful to more easily correct the potassium. Phosphorus, just a point on that, it's a kind of pet peeve of mine how easily, the low threshold providers have to give IV phosphorus for a phosphorus just under 2. There's no data that that's a problem. It's the only data that I'm aware of that phosphorus, when it gets below 1, is you can get into trouble with rhabdomyolysis, so muscle weakness, which get ag. But a phosphorus of 1.8, you know, is probably no big deal, except in maybe refeeding syndromes. If the patient is starved and they're dropping the phosphorus quickly as you're feeding them, then they might need some IV phosphorus. But I really would like everyone to avoid giving IV phosphorus, you know, if your phosphorus is over 1.5, you know, you feed them, you give them oral, use the enteral route. And the reason behind that is phosphorus binds to calcium, and it's probably more in the animal data, but so when you give so much phosphorus so quickly, it will bind to some calcium and there'll be precipitation. So, you know, you probably don't want to.
So if your phos is in like the low 2s, you recommend giving it orally or just leave it alone?
Well, if they're not being fed, then orally. If they're being fed, I would just leave it alone.
Okay.
Now, the only issue is the refeeding syndrome. If you're familiar with the starvation refeeding syndrome, that phosphorus can really plummet. So if a patient has been NPO for, well, I don't know, I think it's more extreme than that. It's usually patients coming in, the anorexic nervosa patients, or patients that really haven't been eating for a couple of weeks. And then you feed them, the phosphorus can plummet. So then you might use, you can always look at the rate of decline too.
So like this morning, there was one of the COVID vented patients had a phos, or exactly, low 2.3, 2.2, something like that. And they wanted to diurese, but they said, let's replete the phos, and then check it later, and then diurese maybe after that. Is that necessary?
No, so what's your understanding of how diuretics affect phosphorus?
I didn't know that it affected the phosphorus at all.
It doesn't, as far as I know.
I don't know what potassium is gonna
I
have.
don't know. So it has nothing to do with phosphorus. Diuretics just get rid of salt.
Right.
And then as a byproduct also gets rid of potassium, but and magnesium and calcium. So it's those electrolytes. But phosphorus, as far as you know, doesn't affect phosphorus at all. So I wouldn't worry about that.
Which electrolytes do you guys take care of during dialysis that are low?
Everything.
All of them?
Yep.
So
So when we're on so the beauty of dialysis is, you probably don't have to worry too much, except for phosphorus.
Okay.
So phosphorus, so if the patient's phosphorus is low, it can get lower on dialysis. So we might have to replace that, but we can correct. So we can correct on dialysis. We can correct obviously the potassium, the bicarbonate, the sodium, and the calcium.
Okay.
Not the magnesium. There's magnesium, a little bit of magnesium correction in the dialysis fluid. There's no phosphorus in dialysis fluid. So during dialysis, the blood it goes against a gradient, a countercurrent gradient of dialysis fluid, and the dialysis fluid contains glucose, sodium, potassium, magnesium, and calcium. So those things can be balanced, and we can adjust those based on the patient's physiology. No phosphorus.
Okay.
So if they're on dialysis, it's always, for me, it's a sigh of relief. I don't have to worry so much about the fluids and correcting this and that.
Okay, thanks.
So anything else before I move on? So monitoring kidney function, another, I think, important point. So acute kidney injury is defined as greater than or equal to 0.3 milligrams per deciliter rise of your creatinine within 48 hours. So that's quite a trivial change. But it's, believe it or not, significant on the GFR, and I'll talk about that in a moment. Or 1.5 times the base creatinine within 7 days. So if a creatinine is 1, and within 7 days it goes up to over 1.5, then that's technically acute kidney injury. Or you have a drop in urine output that's less than 3 milliliters per kilogram over 6 hours, or less than 0.5 milliliters per kilogram per hour. So that, for a 100 kilogram person, that translates to 300, yeah. I mean 300 mils over 6 hours. So yeah, so 300 over 6 hours divided by 6, whatever that is, and then it's 15. So so if urine output is less than 50 cc's per hour for a pretty good sized person for at least 6 hours, that's also a sign of kidney dysfunction. And another thing that's really not appreciated, as we're giving all this fluid to patients, you're actually diluting out creatinine. So that's why this is in there. So you could deceive yourself. You could give someone 10 liters of fluid, and the creatinine bumps from maybe 1.5 to 1.8. You're not too concerned, but the urine output's staying low. It's not pumping. So if you didn't dilute out the creatinine so much, if you kind of kept them euvolemic, the creatinine really would be over 2.5 or something like that. So there is actually a correction factor in our world to base what's the true creatinine based on their total fluid gain. So that's why you have to look at, and I know the surgical staff is well versed on monitoring urine output post-operatively. So, but anyway, so it's just recognizing acute kidney injury early that, now you have to now manage things pretty differently. And this is where we get into trouble with volume overload. We think, okay, creatinine's going up, they must be dry, so let's give more fluid. Sometimes that's correct, but sometimes it's not. So really assessing their volume status, because again, you want to kind of avoid the volume overload. Maybe they're in ATN, they're already volume up. You don't want to give them more fluid, you may want to give a diuretic. So, not every jump in creatinine is because they're dry. But you definitely want to keep them usable. You don't want to give a diuretic to someone who clearly needs fluid. So it's a judgment call on your physical exam. So about the serum creatinine, it's quite deceiving, and I see this all the time, for myself and my colleagues and everybody else, the serum creatinine is just one marker of your kidney function, and it's based on your muscle mass, because creatinine is the metabolite of creatine, which is in the muscle, and it's filtered and absorbed through the kidney, but it's used to estimate kidney function. And you'll see estimated GFRs, which not everybody sees, but so patient, an elderly woman, for example, I don't know what I put here. So so an elderly woman with a serum creatinine of 1.2 may have really a GFR of 40 cc's per minute. We might think that's normal. They must have a good kidney function, but that woman is already starting really with poor kidney function. So take that into account when managing patients. And just subtle changes in creatinine, you should take seriously. So an admission creatinine is 0.8 or 0.6, and then 24 hours later is 1.2. They technically still in the normal kidney function range, but that's not true, because when we look at labs, everything's a static picture. This is a dynamic thing that's going on. So the jump in creatinine from 0.8 to 1.2 in 24 hours, the creatinine hasn't achieved steady state. So so you really can't estimate the true GFR based on that. I could just tell you it's a lot lower than what it appears, because there was a dramatic change in 24 hours. So anyway, the drop, an increase in creatinine from 0.8 to 1.2, translates to at least a 25% drop in GFR. 0.8 to 1.2 is a 50% drop in GFR. So, to be aware of that. And it really affects dosing of medications, really, besides a warning sign, what's going on. As best as we try to treat patients appropriately, managing each part perfectly, it's so easy to allow certain medicines to reach more dangerous levels, like vancomycin. Patients could easily get vancomycin toxic. Even the pharmacists, we don't know what, they base their decision on the creatinine of that day, and they assume it's a static creatinine. There's no formula that I'm aware of that takes into account the change in one day to what is really the new GFR. So patients could easily get vancomycin nephrotoxic because of this changing thing, if it's not appreciated that the GFR really is lower than it would appear. Two drugs that can easily, well, there's several drugs, but I've seen several cases of seizures and other neurological symptoms occur because of cefazolin or cefepime toxicity, because they need to be decreased when patients are developing kidney failure. So, when patients, that's kind of our job when you consult us, to look at all the meds and make adjustments, but just to be aware of that on your end as well, to have to make any changes in their medications based on this. And there's so many medications that can easily get toxic because of changing kidney function. So do the best you can. Before CAT scan with IV contrast, like this elderly woman comes in with serum creatinine 1.2, and then she's maybe also dry on top of it. That's a perfect setup for contrast nephropathy. The biggest prevention of contrast nephropathy is volume, adequate volume status. So if you going to send someone down for an emergent CAT scan with IV contrast, you just need to know, which is fine. Make sure if maybe give them a liter of fluid on the way, assuming they're not volume overloaded, because that will help prevent the contrast nephropathy. And normal saline is fine.
What's kind of your GFR cutoff for a contrast study?
There's really they really don't have a GFR. So the lower the GFR, the higher the risk.
Right.
And it's a case-by-case basis. I mean, obviously, we need to save the patient. You have to know to make.
Yeah, I mean, assuming it's not a life or death study.
Oh, then I would say at least over 30.
30,
GFR
okay.
over 30, and the patient is hydrated.
Right. Okay.
There are risk factors for contrast nephropathy. Patients with poor heart function, reduced EF, diabetes, and myeloma. Those are three classic cases, besides being dry, that there are high risk for contrast nephropathy, even with a higher GFR. And an MRI with gadolinium, the new recommendation is no one gets gadolinium with a GFR under 30. There's a new agent called Dotaram, I don't know. So if you had to do an MRI with Dotaram, you can maybe give it for the lower GFR, but probably not going to be doing much of that in the ICU. So, any questions on that? Yeah. So, and just a little on etiology of acute kidney injury, we break things down into three basic groups: the pre-renal, before the kidney, the post-renal, obstruction, intrinsic, do they have an inflammatory kidney disease, or ATN. The two most common causes are pre-renal and ATN. So, 9 times out of 10, or maybe 8 times out of 10, this is, you'll be one of the two. I don't want to bore anybody with all the details. Anyone have specific questions on the types of kidney failure?
I mean, if you're euvolemic and you're not improving, is it kind of presumed it's ATN at that point?
Could be, that's true, but there are other reasons for pre-renal besides being dehydrated. Other common causes of patients that have cardiorenal syndrome, meaning they have a very weak heart, and poor EF, or severe pulmonary hypertension, so they get a right-sided heart failure. So poor cardiac output causes pre-renal azotemia. And that's always our challenges on the medical floor, is managing these heart failure patients with kidney disease. On the medical side, that's our challenge. Cirrhotic liver disease also affects the physiology in the body. As there's increased mesenteric blood flow, and this contributes to the ascites. It's a diverting blood flow away from the kidneys, so it's called hepatorenal syndrome. So you have hepatorenal syndrome, you have cardiorenal syndrome. There is renal artery stenosis, ischemic nephropathy, which also can give you a pre-renal state. And a lot of drugs can give you a pre-renal picture, especially for those patients with sensitive kidneys, meaning they have scarred up kidneys over years of hypertension and atherosclerosis. So they'll be sensitive to the NSAIDs, which causes pre-renal azotemia. And of course, if you're a transplant patient, the calcineurin inhibitors, like cyclosporin or tacrolimus. So anything that can cause vasoconstriction. Hypercalcemia, believe it or not, is a cause for pre-renal azotemia. Hypercalcemia, calcium over 11 to 12, will cause the renal arteries to constrict. So just correcting the calcium. So the patients could be perfectly euvolemic, but there's a vasoconstriction occurring, so the kidneys are seeing a low flow state. So the bottom line is, there's lots of reasons to cause a low flow state to the kidney, and only one of them is dehydration. So if the euvolemic, they have a decent heart, they have everything else looks pretty good. Yeah, they likely have ATN.
Yeah, I mean, just looking, one of these 55-year-old, relatively healthy guys that have COVID and they're ventilated and their creatinine's now going up and they're euvolemic and they don't have any of those other things.
Yeah, so it's probably ATN. So with COVID, the verdict is out. There are inflammatory kidney diseases, what we call interstitial nephritis, that's related to infections. And certain influenza can cause an interstitial nephritis. So you could have an intrinsic kidney disease, not only from ATN, but from the virus itself. But ATN is, obviously the common thing. So, and then these type of patients, and then, that's the judgment call, do I give them fluid, do I not give them fluid? Are they an ATN? Obviously you could always consult us, but if you could also do, urine studies. You're familiar with urine sodium and fraction of excretion of sodium to help delineate is it ATN or prerenal. So you could do a urine sodium with a creatinine. But if the urine sodium is less than 10, less than 20, it's likely prerenal. No, it's not 100%, but it's likely prerenal. But if this urine sodium is over 20 to 50, or the fractional excretion of sodium is greater than 1%, it's ATN. But obviously you want to keep patients euvolemic, but I think there should be a low threshold, especially in these COVID patients. All right, and not making much urine. They look pretty fine to me, volume-wise. I need to give a diuretic. Just have to give the diuretic. And obviously the blood pressure is good. So you have to weigh a lot of different variables. If that's the right thing to do besides your exam. What's going on in the X-ray could be hard to interpret because they'll have fluffed out. Is it fluid? Is it pneumonia? Not everyone gets the central line. CVPs can be used, so I think an important take-home point for what I wanted to deliver is you're just careful to avoid volume overload, and don't be afraid of diuretics. I mean, I think where everyone's afraid to cause a rise in creatinine, and I have to consult renal now. So it's you don't want So it's just if you're pretty confident they're euvolemic and they're not making much urine, the creatinine is going up, and they're getting all these fluids, just, you might have to give a diuretic.
Is the diuretic to help fix the kidney, or is that just to help with your fluid status?
Just to help with your fluid balance, just to help hopefully keep them off the ventilator or give a better chance. Now, there is it can potentially, when you develop ATN, what happens, these granular casts form and plug up the tubules in the kidney. So actually, I've seen this anecdotally. Diuretics, it can expedite kidney function recovery. They flush out these crystals, these casts. All of a sudden, and I've seen this more than once, many times actually, creatinine's going up, I think they're pretty well hydrated. I just give a high dose of Lasix, urine output opens up, creatinine just plummets.
Yeah, I think that's, for us, we diurese no one in surgery. The surgeons will just call you guys or call the hospitalist and they take care of it. So
right.
Obviously the intensivists diurese all the time. They use Lasix like it's nothing. So I think that's for us, trying to figure out who gets the Lasix, when to use it.
Yeah. So that's a good point. So in surgery, because of third spacing, when you do surgery, you lose fluids from all the interventions. So it's very common they'll get dry easily. So you're very reluctant, for a good reason, to avoid the diuretic. So you want to give them fluid. But these patients are not post-op patients.
Yeah.
So that's a different ballgame. So you have to reverse your thinking a little bit. But for post-op, yes, you want to try to avoid the diuretic unless you're sure they need it.
Yeah.
And then as you know, with post-op patients, so if you have a post-op patient, they get a lot of fluid, they start mobilizing after three days, all this fluid all of a sudden. So then they get into, you really have to sometimes help them diurese so they keep the lungs protected. So meds to avoid an acute kidney injury or to prevent AKI. I know. NSAIDs, everyone knows. COX-2 inhibitors, Celebrex is out there. What's it? Toradol, I assume everyone knows that. That's a bad drug. We think Voltaren gel, which is an NSAID, is safe and generally is pretty safe. It's topical, but I have patients that lather themselves with Voltaren gel, and you can get enough absorption. It acts, it can affect the kidneys. It's also an NSAID, just like steroids. You take enough topical steroids, and also just take a pill, you know. So, so anyway, just obviously if they're, and now with COVID, you know, they're saying NSAIDs would be a risk factor for viral entrance into the cells, so it's a good idea to make sure they're off the NSAIDs if they're in the unit. ACE inhibitors, ARBs, you know, if they're in the unit, we tend to obviously hold them for various reasons. But they're good medicines if in a stable patient, so obviously if someone's unstable, you know, something to hold early on. Metformin, I assume everyone's aware of stopping metformin on patients who are hospitalized because of the risk of lactic acidosis that can occur in renal failure. So ACE inhibitors and ARBs is also theoretically a problem with COVID patients, again, it's enhancing cellular entrance of the virus. So that's more of a problem for us in the outpatient world. Patients are calling, you know, I've heard this, should I stop my ACE or ARB? So, and the answer is no, unless you get COVID. So anyway, so again, for COVID or PUI patients, you know, avoid ACE inhibitors, ARBs. Tecturna is still out there. It's a renin inhibitor. It would act similarly. It's another blood pressure medicine, and obviously NSAIDs. You know, and again, avoiding volume overload. You know, you want to keep the lungs on the dry side. You know, it's always, you know, for the nephrologist and the pulmonary doctor, it's always one of those debates, right? Are they dry enough? Are they wet enough? What's going on? So it's not an easy, sometimes decision-making process. So that's all I had, and I don't know if you guys have questions. Talk about something else.
Not to steal the show, but I mean, if you have a minute, like there was a guy that came in last night to just kind of gather your thought process. So, like an 80-year-old guy who tested positive for COVID as an outpatient, had been hanging out at home, deteriorated, came in through the ER, and then subsequently got intubated last night. When he came into the ER, had lactate of 3.2 or something like that. This morning when I saw him, you know, trended back to normal, 1.2. Had an ABG, his bicarb was a little on the lower side, 19 or 18 or something. Renal function was 1.8 when he got in, was creatinine 1.8 today. Urine, he was only here for one shift, which was 0.2 cc's per kilo per hour. So, kind of, you know, his lactic got better, but his bicarb was still low on his ABG, and, you know, when are you giving fluids versus bicarb trip, and kind of just that clinical application of in that situation, you know,
Sure.
treating the AKI and the...
I mean, do you know what his baseline creatinine was? Do we have?
I looked back a couple of years, he didn't have anything.
Didn't have anything.
Yeah, I mean, he's 80,
He's
so
80.
he could have something.
Right. And then do you have a pH on the gas? You said you had a
7.34, I think.
7.34. And a bicarb of 18. So the PCO2 is probably under 40 then.
Yeah, it was mid-30s, I think, 34, 35.
So it's compensating. So this might be a perfect patient to have on LR. So I
Okay.
wouldn't replace the bicarb, assuming the potassium is okay. And the urine output is pretty low. I know, is it picked up? Is it?
You know, I came in this morning, they
Came
just
in,
had
so
the
no.
shift, you know, he's
Yeah.
only been here 8 hours,
Yeah.
so I don't have a trend
And
yet.
how about hemodynamics? How is he?
Doing okay. Not
So
any
he's
pressures or
not on
anything.
pressors. Yeah. So, my blood pressure is fine. It's not too low, not too high, tachycardic, and so everything.
Yeah.
Yeah, and just your volume. I mean, so it's always good to also look at the exam. Obviously, we're trying to limit our exposure, but swelling, lung exam, JVD. I don't know if he has any signs of fluid overload.
Yeah, I mean, there was a question of whether he was on the drier side because he'd had limited intake at home for the last couple of days while he was sick.
Yeah. So it sounds like just maintenance fluids, lactates down. So I'd probably just switch him to LR.
Okay.
And then a maintenance dose. What's a good maintenance dose? I mean, it's been a while. I mean, it depends on their size. How big is he?
He's not humongous.
Yeah. So for a very obese person, you might, probably need at least for maintenance fluids about 100 an hour or more, and then a tiny woman, probably no more than 50 an hour, so on average 75 an hour. They get fluids otherwise. So yeah, I wouldn't.
If his bicarb low but his lactate's normalized, is that kind of, you don't need to give them bicarb
Right.
per se? But if his lactate was still elevated, you give him bicarb at that point? No?
So that's no. So if the lactate is elevated, so that's the same thing with lactate ringers. If the liver is not working, the liver has to be in good shape to metabolize the lactate or acetate. Let me back up a little bit. So, just think here. So, the fact is lactate is normalized is just a good sign. If his lactate was going up, it's just a sign that, he has tissue ischemia and ongoing sepsis physiology. So we don't treat a lactate level.
Yeah, I guess what I'm trying to figure out is bicarb drips are kind of like Lasix. We don't use them in surgery. So when I see they use bicarb all the time, I'm trying to figure out when are we using that? What's the application of that?
So I would use, so again, here's a good time to just try to prevent the problem. So I put them on LR, and at one point we just switch LR to bicarb, so we're not going to get necessarily an ABG every day, but if you do get an ABG, if his pH is, under 7.25, I'd probably switch him to a bicarb drip. And then, but he may not need to be on, 3 amps. So you could do. We've done this with patients. You just do half normal saline with 1 amp of bicarb, with maybe some potassium in it. And one thing to remember: potassium will go down once you correct the acidemia. So if the potassium is 3.5 and they're acidemic, and you put them on bicarb drip, the potassium will shift into the cells and drop. So you want to add like D5 half normal with 1 amp of bicarb and 20 MEQs of KCl per liter if they're not eating, just to kind of anticipate that. And so it's some bicarb. So you could do like a half normal with 1 amp of bicarb. So it's only if they're really getting acidotic, the pH is under 7.2, the bicarb is dropping, it's 14, 13, 12. Then you want to maybe switch to either D5 or sterile water with 3 amps of bicarb per liter get the bicarb up.
Okay.
So, yeah. Anything else?
Can I ask another patient
Sure.
example?
Yeah.
So we have a patient in the ICU who is BMI 67, he's 500 pounds with diastolic heart failure, who had been getting Lasix because over the last couple months he's gained over 100 pounds. Since he's been here, his creatinine has come up every single day. When he came in, it was like 1.2, then 1.6, then 1.9. Today it's 2.3. And they're trying to keep patients dry with COVID.
Right.
And he's net negative 1.4 liters since he's been here, but his urine output has also dropped every single day. He's like today, or it was like 2.9, 1.3, 850. And so they just had him on like KBO fluids. I think it was somewhere between 10 and 30 yesterday. So the question is, how do you balance someone with diastolic heart failure who also seems to have an AKI in a COVID patient that you're trying to keep dry? And I just didn't quite understand like exactly what we should do for this patient.
It is hard. It's where you have to really, this clinical exam, your clinical exam. What's the chest X-ray look like? It's an ATN, so doing some urine studies could be helpful.
Which we did order those.
But it may not. But at least you could say if the urine sodium is real high, then probably it's ATN. But Lasix, the diuretic, will cause the urine sodium to be higher anyway. And there's no other reasons for the creatinine to be going up. I assume his blood pressure is
Low.
low.
Yeah, it's like been like low 100s, over 50s. He was on antihypertensives. We obviously held his lisinopril.
Mhm.
And he hasn't been getting the Lasix the past like 2 days.
Is he on pressors?
Yeah.
No. Yeah. So that's a tough one. That's a tough one, is right. So, that's where, dealing with the pulmonologist, can we give him a fluid challenge? Is he on the verge of being intubated? So,
Yeah.
these diastolic dysfunctions is tricky. Diastolic dysfunction, it's a strong heart, it's just very stiff. And then some of these patients have pulmonary, these obese patients have, pulmonary hypertension, which could be cause a little right-sided heart strain, and or even weaken the right ventricle. So you have even a further reason for poor cardiac output, but it's more dependent edema. It's not affecting the lungs. It's more edema or ascites that can occur from that. So it can get very tricky. Do you have weights on him since he's been here?
I don't know.
I don't think his bed can calculate.
Yeah, I honestly, and he's also
Yeah.
not, they can't get a bariatric bed in there now that he's COVID, because they can't open the room up enough to get it in there.
Yeah. Wow, that's a tough one, and these obese patients, it's just hard to get a feel for their volume status. So I would probably,
I'd consult nephrology
Yeah,
today.
yeah.
Just because, they would, even Dr. DeDios was like,
Yeah.
this is beyond me now.
Yeah, and these are the
But I'm
patients
just
that,
curious.
the obese African Americans, they die. It's just one of those hard situations. So, they're not going to die from kidney failure because we have dialysis. So
Yeah.
if you're really on the verge of, so it's a judgment call. I mean, what to do? Obviously, minimize nephrotoxins. In these patients, some patients, having a little higher blood pressure can help renal perfusion. We use midodrine or obviously Levophed if needed if they get too low, but getting the blood pressure up maybe sometimes allows a little better kidney perfusion and diuresis. Obviously, too high of a blood pressure can stiffen the heart and aggravate diastolic dysfunction. But it's a difficult scenario. So even if I said one thing, it could be wrong, and it's just sometimes you don't know until you try something, and then you see what happens. You just give your best thought. But anyway, it's if they can afford the fluids, they usually do that. But if they're at risk, if they're really on the verge of intubation, you're kind of stuck.
Is that where you sometimes err on the side of, saving the lungs and letting the kidneys take a hit because you can dialyze them versus
Right. Exactly right.
the lungs?
But once they're intubated, if sometimes and they're not on much oxygen.
Yeah.
If they're on 30% FiO2, 40% FiO2, the chest X-ray is really not clear. The kidneys are going down, urine output's going down in this type of patient. Let's give them a fluid challenge and see what happens. You could just do a 500 cc fluid challenge. If the urine output picks up, the creatinine comes down, you're in good shape. If there's no improvement, there's probably ATN, and you just have to manage the patient that way and try to avoid the volume overload and dialyze if necessary. So, anything else?
Anything else?
All right.
No, thank you very
Sure.
much.
All right.
Yeah.